Hi, everybody. I'm Dr. Kim Evans. I'm here today with Dr. Haloya, and we're going to be talking about surgical treatment of breast cancer. First, just a little bit about myself. I am a general surgeon. I've been at Barton for 10 years. I trained at UC Davis, and I see a lot of patients with breast cancer. So we're happy today to talk to y'all and give you just a little bit of idea of what it is that we do and how we can work together to improve your outcome. All right, so just first, real quick, kind of what to expect at your first visit. I didn't want to just jump right into the way that we treat this surgically. So the first most important part is that you're going to meet your surgeon. So you want to get to know them, find out if you like them, because you're going to be with them for a long time. I see all of my breast cancer patients for 5 years after surgery because it's very important that we do follow-ups to make sure that there's no signs of recurrence. And it's actually kind of difficult when someone's had surgery for a non-surgeon to tell if it's just scar tissue, if there's something else more concerning. So we really like to have you follow up with us during that 5-year period to make sure that there's no signs of recurrence. And you want to make sure that you get along with your surgeon, make sure that you mesh. Next, we're going to discuss your pathology. So we'll discuss type of cancer. The two main types are ductal carcinoma and lobular carcinoma. And we'll also go into the molecular biology, which sounds like a lot, but it's really important in breast cancer treatment. So we do go over molecular markers, and those include the estrogen receptor, progesterone receptor, and the HER2 new status of the tumor. These are really important in terms of how we treat for individual specific cancer. We'll then talk about staging workup and what needs to be done. We'll also discuss the multidisciplinary approach to cancer. So whenever we see a patient with breast cancer, we want to involve not just surgery, but also the medical oncologist, the radiation oncologist, plastic surgery, and there's also a psychosocial support component that we will discuss. Sometimes it involves even more people, but that's sort of the beginning group. We'll perform a physical exam, and then we'll go over your surgical options. All right, so what are the surgical options? There's actually 2 treatment categories. We do both types of surgery at the same time, but I discuss them differently because it is technically 2 different procedures. So first we're going to talk about surgical treatment of the breast, and then next we'll talk about surgical treatment of the axilla, which is just a fancy word for armpit. So we do remove the lymph nodes from the armpit. And we call that axilla. So just, I'll be using those words interchangeably, and I'll make sure that you know what we're talking about when we get there. All right, so first, surgical treatment of the breast. There are 2 main options, 2 ways that we treat breast cancer. The first is lumpectomy, and the second is mastectomy. And we're just going to go into a little bit more detail about both of those. So with the lumpectomy, we make a relatively small incision. So depending on the size of the tumor, anywhere from this big to about that big. And then we take out the cancer and also surrounding healthy breast tissue. When the cancer is too small to feel, we will put in a special marker so that I can find where to go during surgery. And then we take an x-ray of that specimen to make sure that we've removed the correct portion of the breast or the correct part of the breast. It's important in order to do a lumpectomy, we have to make sure that the mass is relatively small compared to a woman's breast size. So you can imagine if there's a big lump in a woman that has a relatively small breast, that makes it more difficult. There are some relative contraindications. So a tumor that's greater than 5 centimeters, if a patient is unable to have radiation, if there's multifocal disease, meaning it's in multiple areas of the breast, or if a patient has a known genetic risk of increased recurrence. So meaning that they have a higher risk of it coming back than the standard patient. Those are times when we would talk about recommending mastectomy over lumpectomy. Now, let's just talk a little about what a mastectomy is. So when we do a mastectomy, we remove the entire breast. Traditionally, this includes the nipple areolar complex, which is here where you can see the areola nipple. There are variations, which include skin-sparing mastectomy and nipple-sparing mastectomy. The standard mastectomy incision, you'll see there's just a relatively straight line scar where the breast used to be, and this is a breast without reconstruction. So this is mastectomy without plastic surgery in this picture. The skin-sparing mastectomy, we take a lot less skin, so we leave more behind, which allows for reconstruction, allows space and volume for reconstruction. And when we do a nipple-sparing mastectomy, we are actually leaving behind the nipple and areolar complex. This is not always possible in cancer patients. It is done more frequently in patients where the surgery is done prophylactically, meaning to prevent cancer, not treating cancer. But in certain instances, it can be done for cancer patients as well. After a mastectomy, it is a big operation. Most patients do stay overnight. We will place a surgical drain. And it's important to know that a lot of patients, most patients are candidates for reconstruction. So when we're talking about mastectomy, it is really important that we bring in our plastic surgery colleagues to discuss that option. And this is just picture looking at the two different types of surgery. So on the left is this is a modified radical mastectomy, which I know is a lot of words. So in a modified radical, we're taking the breast and all of the lymph nodes, and we're going to talk about the lymph node part later. And just a standard mastectomy, we're removing this breast portion here, and we're not taking all of those lymph nodes. And this is just another example from the side of what it looks like when we're doing a mastectomy. We are leaving the muscle behind. We do not take the muscle with a standard mastectomy. And then with a lumpectomy, which is this picture over here, on the right, we're taking a small area of healthy tissue around that tumor and then removing it and obviously closing the skin over the top. All of these images, I have put links and references. So these are from the American College of Surgeons. I'm not a very good artist, so I definitely am not drawing my own pictures. You would be able to see what is going on if I did. Okay, so when do we choose? When do we recommend one versus the other? Well, it's gotten a lot easier than it used to be. So back before I even went to med school or was in training, most patients would have a mastectomy, but there was this really important critical paper that came out in 2002, so over 20 years ago. And it was the NSABP06. And this is just a series of studies that have looked at breast cancer, but this is the NSABP06. And over 1,000 women were enrolled all the way back to the 1970s. And they had a minimum 20-year follow-up. So it was a wonderful study, really well done, long-term follow-up. And they looked at modified radical mastectomies, that's what we're talking about before, where they removed all those lymph nodes because that used to be standard of care, and versus lumpectomy with radiation. When they looked at the mastectomy versus lumpectomy with radiation and lumpectomy, there was no difference in overall survival. So whether you have a lumpectomy or a mastectomy, your odds of surviving your cancer are equivalent. They're the same. So choosing a mastectomy, and this is not in patients who have genetic increased risk, but a standard patient, it is not going to affect your long-term outcome if you choose, as long as you're candidate for lumpectomy, if you choose lumpectomy or mastectomy. When you look at mastectomy with radiation versus or lumpectomy with radiation versus mastectomy, there was no difference in recurrence rate. Now, if a patient has lumpectomy without radiation, the local recurrence, meaning the chances of cancer coming back into that breast, was much higher. So it's important, it was 3 times higher if the patient had lumpectomy without radiation compared to lumpectomy with radiation. So very important, if you have a lumpectomy, it is important that is followed by radiation. There have been several follow-up studies which have confirmed these results. This is not even though this was such a good study, it has been looked at multiple times since, and we have reconfirmed that survival and recurrence rates are similar. And we're talking every study, there'll be a difference of like 0.5%. So they'll go back and forth, but they're equivalent when we look at lumpectomy with radiation compared with mastectomy. So how do we decide which one to recommend? Well, the first is it's really up to the patient. So as long as there is not a reason, and as long as there's not an indication where we say you're not a candidate for one or the other, then it's really up to the patient and what they want. So we talk about risks and benefits, pros and cons. When we talk about lumpectomy, it's less invasive. Patients able to keep a majority of their breast. They usually go home the same day after surgery. It's a shorter recovery time. But there are some downsides too. So there is a risk of what's called a positive margin. The national average is 20%. And that positive margin would mean that there's cancer on the outside. So let's say this is the cancer specimen. If there's cancer on the edge, then we would have to go back and take more tissue. The national average is 20%. The national average for people who do a lot of breast surgery is 12%. Our average here is 12%. So we do track that, and that is a risk of lumpectomy. Another downside to lumpectomy is that it does require postoperative radiation in most cases. Now, there is a small percentage of patients that doesn't have to have radiation, and that's based on age and other factors, but the majority of patients who have lumpectomy, we are going to recommend radiation. And standard radiation is about 6 weeks, 5 days a week of treatment. But again, you get to keep your breast. So that is the one downside. And then the other is that it does require ongoing surveillance. So when you've had breast cancer and you still have your breast, we're obviously going to continue to recommend surveilling that breast. Some women just don't want to do that. They don't want to have the imaging after surgery. And so they may choose a mastectomy for that reason. Okay, so for mastectomy, it is a larger incision, bigger operation. It involves loss of the breast and most often, additionally, the nipple. Most patients do require an overnight stay in the hospital. There is a longer recovery time. It is more painful than a lumpectomy. Benefits, though, it does not usually require radiation. So there are some instances where it does, but most of the time it does not. And then the other benefit is that these patients no longer need ongoing breast imaging and frequent mammograms because they no longer have the breast. Okay, so when I talk to patients and counsel them, I really just say, I give them the pros and cons. We talk about these, we talk about surgery, and then it's really up to them on which choice they would prefer. And it's important that we tailor that decision with what the patient values most and with what they want going forward. All right, so now we're going to talk about surgical treatment of the axilla. So like I said before, they're done at the same time. It's one operation, but it's really kind of like a 2-in-1. So we treat the cancer in the breast, and then we also look at the lymph nodes in the armpit or the axilla. Okay, so this is, again, performed simultaneously and allows for staging of the lymph nodes. Whenever possible, we do what's called a sentinel lymph node biopsy, and this removes a lower amount of lymph nodes. Sometimes, though, we do have to do what's called an X-ray lymph node dissection. We always try to do the sentinel lymph node biopsy whenever possible because there's a lower incidence of lymphedema and a lower incidence of nerve injury. All right, so we're going to talk a little bit about the sentinel lymph node biopsy first, and then we'll talk about the X-ray lymph node dissection. So the way that we find this is a picture that shows a breast and it shows the lymphatics in the breast. The lymphatics are separate channels, just like we have arteries and veins to carry blood. We have lymphatics that carry the lymph or fluid that goes between the lymph nodes. We put blue dye and a small amount of radioactive material into either the tumor or around the nipple. And then it finds its way into these little channels and it helps us find what I usually refer to as like the catcher's mitt of lymph nodes. So if cancer is going to leave the breast, it goes to that catcher's mitt lymph node first. And this could be 1, it could be 4. There's not always just one, there are often several. And we're able to identify this lymph node 98% of the time. And studies have shown that it is very good, it is very reliable. If the sentinel lymph node is negative, the odds of having a clinically concerning lymph node in another area are extremely low. In like 15 years ago, when we found positive nodes on sentinel lymph node biopsy, we would often have to go back and do the full X-ray lymph node dissection. Most of the time that is no longer required. And I won't go into all the details about all the studies that have been done, but we have done a lot of studies that show that most of the time, and we have very specific criteria, we don't have to go back and do that secondary X-ray lymph node dissection. The benefit, like I said before, is there's a lower risk of lymphedema and a lower risk of nerve injury compared to X-ray lymph node dissection when we do the sentinel lymph node biopsy. Okay, and let's talk a little bit next about the X-ray lymph node dissection. So this involves removal of all the lymph nodes, we call them level 1, level 2 of the armpit. And it is required in certain instances. So let's say a patient comes in and has what we call a clinically positive node. So if we can feel a lymph node on physical exam, if they have 3 or more positive nodes on sentinel lymph node biopsy, or if they have positive nodes with a very large tumor. So again, we try not to do this whenever possible, but sometimes it is required. All right, so now I'm going to pass it on to Dr. Haloida. She'll be talking to you about reconstruction options.
Great. All right. All right, and we can see this okay? I hope. Okay, so I'm Dr. Halite. I'm the plastic and reconstructive surgeon here at Barton. I have been here about 3.5 years. I completed my training in microsurgery at University of Chicago, did my plastics at University of Utah, and I'm excited to talk to you about breast reconstruction today. So this is the basic plan for the next 20 minutes or so. Just as Dr. Evans alluded to, the diagnosis and treatment of breast cancer takes an entire team. It's not just the two of us. Once diagnosed, the team includes, as she mentioned, a breast surgeon like Dr. Evans, who performs the surgery to treat the breast cancer, radiation and medical oncologist at the very least in consultation to see if these adjuvant therapies are required. Hopefully, a plastic and reconstructive surgeon who specializes in reconstructing the breast mound and making you feel whole again. And then, as you can see, it's a host of many supportive members of the team, including social workers, nurses, physical therapists, and even support groups online or in person to help deal with the diagnosis. Before we get into the nitty-gritty of breast reconstruction, I just wanted to talk about an important piece of legislation called the Women's Health and Cancer Rights Act of 1998. So this is actually a federal law that provides protections to patients who do choose to have breast reconstruction following a mastectomy, and applies to all healthcare group health, to all group healthcare plans that are provided either by an employer or by a union, as well as individual health insurance policies. So this law states that insurance must cover all stages of breast reconstruction, all symmetry procedures on the contralateral breast, and it's also forces coverage of prosthetics as well as treatment of physical complications. It's also important to note that this Women's Health and Cancer Rights Act does not have a time frame limitation. So if you are going through a lot at the time of your diagnosis, you can always seek reconstruction at a later time, which we will talk about. Now, going off of that, why would anybody bother to choose reconstruction? After all, it is an elective surgery, meaning that my portion of the procedure is not life-saving, it's not limb-saving, and it may come with its own set of complications. So to address this, I start every breast reconstruction visit with a patient the same. I explain that they may meet me, think I'm a nice enough person, but breast recon is just more than they can handle at that time, and it's more stress. And if that's the case, I get it. Breast reconstruction is absolutely optional. At the time of surgical treatment for breast cancer, there are many, many things going on in a patient's life. They have a recent diagnosis of cancer, which is in and of itself very scary. Dealing with the fact that you may lose your breast. You may be dealing with side effects of chemotherapy when you meet me. I understand all of these and I respect your decision anyway. Furthermore, my goal is never to interfere with your cancer treatment. I'm here for support, to provide information, and ultimately, hopefully to make patients feel whole again that do choose to pursue breast reconstruction. And as far as the plastic surgery literature is concerned, the benefits of breast reconstruction do include a psychological benefit in the short and long term for women who elect to undergo breast recon. It also eliminates the need for external breast prosthetics, which can be rather cumbersome. It avoids clothing limitations and does help patients regain a sense of femininity and wholeness. On the other hand, some women decline breast reconstruction because they either fear the complications, there's a sense that they are too old, or they fear that it will interfere with their cancer treatment and surveillance in the future. So there are two different classification systems that I need to go over quickly in the algorithm for breast recon. The first deals with timing. So we'll begin by talking about immediate versus delayed breast reconstruction. Immediate breast reconstruction, meaning it's performed at the same time as the mastectomy or the lumpectomy, has its own set of advantages and disadvantages. Advantages is that overall it allows a better cosmetic result because anatomic landmarks are preserved. And as Dr. Evans mentioned, there's also usually a skin sparing mastectomy, so more skin is preserved as well. Important landmarks that are preserved are the inframammary fold, which is where the breast meets the chest wall, And in delayed breast reconstruction, this can often become scarred down and become obliterated. The other benefit of immediate breast recon is that women never experience a completely flat chest. So there's a psychological benefit to immediate breast reconstruction. Obviously, there are also disadvantages to immediate breast reconstruction. Disadvantages can include difficulty in assessing the mastectomy flap viability. So as you can imagine, when Dr. Evans removes all the breast tissue as shown here, it's been in that arrangement for a very long time. We're taking away all the underlying support of that overlying skin. We're also taking away the blood supply to that skin. So if a patient is particularly thin and doesn't have a lot of subcutaneous fat, there may be issues with the viability of that skin overlying an immediate breast reconstruction, because we're counting on the blood supply from the periphery to kind of make up for it. Also, in the setting of postoperative radiation, this can sometimes negatively affect the appearance of a breast reconstruction. In this case, we try and avoid that by doing it in a staged approach to minimize its effect. Radiation is very important, and when it is recommended, I highly recommend pursuing it because it's necessary to improve longevity and disease-free survival. But the changes that radiation makes do change the physiology of all the tissue that it touches for the lifetime of the patient. So acute radiation complications can include burns and skin changes, while prolonged effects can include destruction of capillaries and some of the small blood vessels in tissues that plastic surgeons rely on. So if there are any complications with an immediate breast reconstruction, sometimes this can minorly delay chemotherapy and radiation. So if there are any complications, usually I recommend removing and starting over after appropriate therapy has been delivered. So obviously the other side of that is delayed breast reconstruction, which carries its own set of advantages and disadvantages. We see here delayed breast reconstruction with an implant technique on the left and with bilateral free flaps on the right. So with delayed breast reconstruction, obviously there's absolutely no delay in postoperative chemotherapy or radiation administration. And delayed breast reconstruction overall tends to carry a lower complication rate. If radiation therapy is necessary, damaged skin can be removed at the time of breast reconstruction and replaced with healthy tissue. You can see that really well on this right side where the tan tissue has been removed and it's been replaced with healthy non-irradiated tissue in the form of a free flap from the patient's abdomen. So the disadvantages, hopefully you can appreciate here, is that you really do lose the original shape of the breast, which is an advantage in immediate breast reconstruction. There's also the disadvantage of that psychosocial stress of living with a flat chest or a mastectomy defect for a period of time. The second type of classification of breast recon is the materials used for the actual reconstruction itself. So first I'll talk about breast implant-based reconstruction. It is the most common form of breast recon in the United States. Overall, implant-based reconstruction has no additional morbidity, no additional scarring when you compare it to the mastectomy itself, which is a great benefit. It also involves a shorter operative time and a shorter recovery time compared to autologous. The surgery for implant-based reconstruction is either outpatient or an overnight stay in the hospital. And then complications that we worry about are mainly related to the presence of a foreign body or the implant in the body. So infection, extrusion of the implant, or again, we worry about the skin flap necrosis on superficially. Over time, the other concern we have is capsular contracture or hardening of the tissues around the implant, which may require revision in the future. And then lastly, we do worry about implant rupture. Implants are not designed to last forever, so sometimes they need to be replaced. Implants can either be silicone or saline, and if you ever need to, I am happy to discuss the advantages and disadvantages of each. So often with implant-based breast reconstruction, we start with a tissue expander. So a tissue expander is essentially a surgical balloon. It occupies the same space as the breast implant. And at the time of the mastectomy, when Dr. Evans removes all the breast tissue, the tissue expander is placed usually underneath the pec muscle and it's filled with a small amount of normal saline. This is a great technique because it allows me to control the mastectomy flaps, make sure they look nice and healthy, and the patient has a small amount of volume immediately after their mastectomy surgery. And then after the initial placement of the tissue expander, the patient returns to the office. Once healed from their mastectomy and tissue expander placement, we actually start expansion in clinic. So we inject more and more saline into this port that you see here until the patient looks down and is happy with the volume that they have achieved. So in this panel here, we see our preoperative photo, and then in panel B, this is when the patient is filled to the volume that she desires. So with a tissue expander placement, there is a second stage in breast recon. Once the tissue expander is full, it's left in place for a minimum of 4 to 6 weeks. This allows the skin to stretch and heal and be completely healthy when the tissue expander is replaced with that final implant. And so in panel C here, we do see the final implant placement. It is important to note that if chemo or radiation therapy are needed after the mastectomy, it takes place at this stage right here, stage B, when the tissue expander is filled to the completely desired volume. So in the setting of no radiation, a tissue expander can simply be replaced with an implant. It's an outpatient procedure, very easy, and compared to the mastectomy, a very well tolerated procedure. However, in a patient like this one, and I apologize for the quality of the photos, we see a lot of radiation tanning. That tissue expander is really high and tight. So it would be irresponsible to just exchange that for an implant. We need to bring in healthy, non-radiated tissue from another location to cover up that implant, protect the implant from the outside world, and protect the implant from the radiated tissue. So in this case, we can also bring in a latissimus dorsi muscle flap. So a piece of the back skin and muscle is brought through the axilla into the front, and that provides good bacteria fighting, good blood supply, and it really helps to reduce complications from radiation changes. The final type of breast reconstruction I want to talk about is complete autologous breast reconstruction, where we use the patient's own tissue to create the breast mound and volume. So free flap breast reconstruction is essentially a transplant operation without any immunosuppression. Tissue is physically removed from one area of the body along with its blood supply, and that blood supply is connected to recipient vessels in another part of the body. The most common free flap procedure performed for breast reconstruction is the DIEP flap, the deep inferior epigastric perforator, or DIEP flap. During this operation, we use the blood vessels that feed the skin and subcutaneous tissue above the fascia, and we physically remove them, disconnect them from the abdomen. Blood vessels in the chest are then exposed to receive the free flap. These are the blood vessels that are going to supply the blood to keep it alive. And these are usually the internal artery, the internal mammary artery and vein, just lateral to the sternum. So these blood donor vessels, again, usually the IMA and IMV, are anastomosed or connected to our free flap artery and vein. This is performed under the microscope because these blood vessels are usually very small, about 1 to 3 millimeters in size. And as you can imagine, with something that's small, precise suture placement requires a magnified view. So here we see a completed anastomosis. Here's the artery with blood flowing into the free flap down here. And our vein is connected with what's known as a coupler, which is a device that we use because the walls of the vein are usually very thin. So the advantage of the autologous breast reconstruction is that it's the patient's own tissue. If the patient loses weight, it will get smaller with them. If they gain weight, it will get bigger with them. Patient also gets a little bit of a tummy tuck, which is nice because all of this tissue below the belly button is removed and used to create the breast mound. As I showed you earlier, it can also replace damaged radiated tissue with healthy, well-vascularized tissue. Complications from this usually deal with blood flow to and from the flap. So if there was any compromise of flow into the flap, that's cause for concern. Similarly, if the blood is pooling in the flap because it can't get out, that is also a big concern. Patients can also get fat necrosis. What this means is hard little nodules develop in the chest and they're palpable through the skin. This is usually because the flap is a little bigger than the blood supply that it provided. They can be managed either with scar massage or sometimes they actually need to be completely removed. And then this compared to implant, we have a secondary donor site. So in the abdomen, there can be complications associated with that too, including hernia or sometimes seroma. So the main difference is that the autologous breast reconstruction is a huge investment up front. It is all day in the operating room, usually into the night. It's a much longer hospital stay up front compared to all other forms of breast reconstruction. And recovery does take a full 8 weeks. But after that, it's your own tissue. You don't have to worry about an implant rupturing or needing to be replaced or capsular contracture. And finally, I just want to touch on something called oncoplastic breast surgery. Dr. Evans and I have done a couple of these over the last couple of years. And basically, this is just rearrangement of breast tissue in order to avoid dents, more scarring, or distortion of the nipple following a lumpectomy. There's 3 different levels of oncoplastic procedures. The first level can be used when there's less than 20% of the breast volume. And this is just simply performed by tissue rearrangement through the exact same incision that Dr. Evans used. There's no extra skin excision and there's no reshaping techniques performed. Level 2 is when a greater percentage of the volume of the breast is removed, about 20 to 50%. For these, usually nipple displacement or recentering procedures are included. So it's kind of like achieving a lift at the same time as your tumor excision. And then finally, level 3 oncoplastic breast procedures is when truly too much volume has been taken with the lumpectomy and there's not enough tissue in the breast to move around, resulting in asymmetry between the breasts. So this is usually managed with local transposition flaps or fat grafting. So what is a transposition flap? That's where I take tissue, usually from the side of the chest, and move it into the breast in order to replace missing volume. So as you see here, a LICAP, also known as a lateral intercostal artery perforator flap, or an LTAP, a lateral thoracic artery perforator flap. These are perfect examples of these, which are very useful for the lower outer quadrant defects. Another option to replace breast volume that usually requires multiple treatments is fat grafting, as pictured here on the right. So fat grafting is a process that involves harvesting fat through liposuction, either from the abdomen or usually the medial thighs, sometimes the flank. It's processed sterilely in the operating room, and then it's injected into the appropriate location so that we can improve the appearance of the breast and kind of fill up that area. Unfortunately, with fat grafting, there is a resorption rate of about 40 to 50%. So it does require multiple treatments. The average is about 3 sessions spaced 3 months apart. And finally, we'll talk a little bit about revision surgeries. So after a patient is healed from their breast reconstruction, there may be significant asymmetry. As you'll remember, the Women, Cancer and Health Rights Act of 1998 does cover symmetry procedures. So here we can see a very big difference in the treatment. After receiving treatment for breast cancer on the right side, the patient was able to undergo a breast reduction on the left side to achieve better symmetry, and it was covered by insurance. Over time, sometimes contour irregularities can develop in a reconstructed breast. This is either an implant or autologous, and these can be addressed with fat grafting. And then literally the cherry on top of breast reconstruction is nipple reconstruction. It's definitely an option for women with either implant or autologous breast reconstruction. Usually takes place at least 6 months out after all revisions have been performed. And this way, the shape of the breast mound is well established and the nipple can be created in the optimal position. It's definitely an optional procedure, and I would say about 50% of my patients actually end up pursuing it. There are other options for nipple reconstruction, including pasties, which are just stick-on nipple areolar complexes that can be reused. 3-dimensional tattooing, which actually has come a very long way in recent years, or a short procedure as illustrated here that I can perform in the clinic under local anesthesia. This form of nipple reconstruction provides a little bit of projection, and the biggest complaint with it is sometimes the nipples flatten over time. So obviously we could go into great detail about everything I've talked about today, and I want to just touch briefly on a complication of breast cancer treatment called lymphedema. This is in a treatment that is actually changing currently and has dramatically changed over the last decade. So lymphedema can occur following mastectomy, and it's increased risk of developing after axillary lymph node dissection. And so what lymphedema is a buildup of fluid in the soft tissues when the lymphatic system is damaged or if it is blocked. So these lymphatic vessels can be damaged by lymph node dissection, by radiation treatment, or from the cancer tumor itself. The lymphatic system is just as important as our arterial and venous systems that deliver blood to our heart. When this system becomes unbalanced, lymphedema can occur, and it's uncomfortable, and it can also result in multiple episodes of cellulitis or an infection of the skin. So initially, lymphedema is treated non-surgically. And as of today, even with the techniques I'm going to talk to you about, there is no cure for lymphedema. The non-surgical measures that we use are the standard of care, and they definitely help to reduce swelling, reduce the number of cellulitic episodes, and can relieve symptoms. So the treatment is guided by a physical therapist who is certified in lymphedema. It includes exercise, weight loss, compressive devices, wrapping of the affected limb, manual massage, and pneumatic pumps. If symptoms are very severe and persist even after at least 3 months of therapy, then we can start to consider surgical interventions for the treatment of lymphedema. And we're fortunate here at Barton that we do have physical therapists that specialize in lymphedema, and they are absolutely wonderful. So there's two main types of surgical interventions offered for the treatment of lymphedema. The first is called a lymphovenous bypass, as illustrated here on the left. This is performed under a microscope, and a surgeon such as myself uses very small instruments and sutures to connect a blocked lymphatic vessel to a nearby vein. The diameter of these lymphatic vessels can be as small as 0.2 to 0.3 millimeters, but this bypass allows fluid to completely bypass the obstruction proximally, go into the vein, and help decongest and decrease the volume of the affected limb. The second, more involved version is a vascularized lymph node transfer, which, like the autologous breast reconstruction, is essentially a transplant operation within the same patient. So we can take lymph nodes from either the supraclavicular region, as shown here, from the groin, or from the posterior thoracic lymph nodes over the serratus muscle. We remove them with their blood their blood supply, and connect them to blood vessels in the affected limb. Now, this takes about 2 to 3 years to actually start taking effect, but the vascularized lymph nodes that get moved send out little signals to try and reach lymphatic channels that are working, and they connect. And after that connection is made, there's a appreciated reduction in volume. And then finally, there is the horribly named LYMPHA procedure, which is short for lymphatic microsurgical preventative health approach. And this is a great procedure, which I'm very excited about. And actually, Dr. Evans and I need to talk about it a little bit more. This procedure is actually performed at the time of any axillary lymph node dissection. So it involves preserving a few of the lymphatic channels from the arm that drain into that same axillary lymph node basin, and then taking those lymphatic channels and connecting them into a single vein. So current evidence does suggest that this can help reduce the incidence of lymphedema following an axillary lymph node dissection. So we got through all of that very, very quickly. I hope there are some questions out there, but I do want to thank everybody for their time, and thank you for joining us tonight. And we are happy to answer any questions you might have.
Great, thank you. We've already gotten a couple in, and if you do have questions, you can ask them in the Q&A box or in the chat box. There is an anonymous option if you do want to ask a question in the Q&A box that way. The first question is, can you start with a lumpectomy, but during surgery have to change to a mastectomy?
So I'll take that one. So no, we don't, go into lumpectomy with the option of mastectomy at the time of surgery. We do make that decision with the patient before we go into the operating room. There are instances where if the path report comes back and there's a significant, if we have positive margins or if there's much more significant disease than we were anticipating, and those two go hand in hand, then we would bring the patient in the clinic and talk about potentially doing either another lumpectomy, which is called a re-excision lumpectomy, or a mastectomy. But we do not make that decision in surgery. We make that decision ahead of time.
Great. And can either of you talk about the coordination of care? So if someone had a surgery elsewhere, how does that work to come in to see the plastic surgeon, or even vice versa? I don't know who could take that. It's more of a broad question.
If I'm understanding it correctly, if the reconstructive process has already started or they've already undergone one stage of reconstruction, I'm happy to see those patients. I have a few of them right now. And people come in for various reasons. I've seen people because they're unhappy with their original reconstruction and it's not important to them anymore. I've had people who want to have it revised. I'm happy to see you at any stage, and if there's anything I can do to help, I'm happy to talk to you about it.
Great. The next question is, do implants have an expiration date? Do they need to be replaced at some point?
Yes, is the short answer. Implants are guaranteed between 10 and 12 years. They are not lifelong devices, and after that point, the risk of rupture increases by about 1% per year. And yeah, they should be replaced. We are kind of in a strange time because right now women are coming in, and if they've had their implants for 10 or 12 years, and this is even breast augmentation patients as well, if there's no problems with them, we don't remove them and necessarily exchange them. So that leads to the question of when should we be taking them out and exchanging them? Because I have also encountered people who have had their implants for 40 years, and obviously that's too long to have those devices. So if there's an issue in the first 10 years, they absolutely need to be replaced. And then at the 10 to 12 year mark, we start talking about replacing them. In breast cancer patients, it's a little easier because insurance will cover it. In people who pursue more elective procedures, it's a little hard to justify getting a whole nother surgery when you don't have any problem with your implants. So yeah, that in answer to your question, they do have a warranty on them, not necessarily an expiration date, but they should be replaced.
The next question is, if there are 3 cancerous spots and they are across 2 quadrants, would you most likely do a mastectomy or a lumpectomy?
So that's a good question, and it honestly depends. So most often, yes, if you're having that many different areas of disease. We used to be very specific about breast quadrants. So if you divide the breast, there's an upper half and a lower half and an inner half and an outer half. And we used to say if they're in 2 different quadrants, then you should definitely have a mastectomy, not a lumpectomy. But if you have 2 lesions and 2 quadrants that happen to actually be really close together, then you can remove both of those, even if they're in the same area. When we're seeing upwards of 3 cancer areas, that's where we get concerned that there's probably disease all over the breast. And I would counsel a patient about leaning towards mastectomy in that case.
The next question is, if you have a skin sparing surgery mastectomy, do you still have to have tissue expanders? Can the implant be placed on top of the muscle?
That is an excellent question. It depends on the goals of the patient. So if the patient would like to be significantly bigger, I don't recommend direct to implant reconstruction because the mastectomy skin flaps, like we talked about, already have a decreased blood supply. And that's a lot of stress if you're trying to increase the size. However, if they just want to be approximately the same size or even better, even just a little bit smaller, we can do direct to implant reconstruction, so, which is great because then it's a simple, well, it's not simple, pardon me, but it's a single operation with a one-night hospital stay, and that's a really great option for patients that their reconstructive goals align with the physiology and making that possible. And prepectoral placement in front on top of the muscle is very popular right now. I discussed that with my patients as well for pre-pec versus sub-pec placement. So some people are candidates and some people are not. So it kind of depends on the patient's exam, their measurements, and again, what their goals are.
Okay, I do see that a hand is raised, so I will allow them to talk after this next question. The next question is, have you ever done a mastectomy on someone who has a defibrillator? I am having a problem saying that word. If so, are there any complications or risks?
So, the longer answer here, so yes, I mean, I've operated on patients with defibrillators. Usually in patients who have a defibrillator, they have it for a reason. And so if it's at all possible, I would like to perform a lumpectomy and not a mastectomy in that patient population because it's a shorter operation, less stress on the heart, less cardiovascular risk during the operation. Is it possible? Yes. We do always test patients with defibrillators. There's a special device that we can use before going into surgery to make sure that it's safe to operate. But again, in a patient population that requires a defibrillator, we would have a discussion about potentially leaning towards lumpectomy if at all possible because of the shorter operative time and less stress on the heart.
Okay, I'm going to go ahead and see if this person who's raised their hand wants to go ahead and ask a question. So go ahead. If you can hear me, you can unmute yourself and ask the question. And if there are other questions in the meantime, I'm happy to ask them. Oh, looks like they lowered their hand. All right. There's another question that's come in. For breast cancer patients, do you belong to a group that does case conferences with oncology to collaborate care?
Yes, so we collaborate care with Tahoe Forest. And there is a greater group where they have multidisciplinary conferences where we can talk about patients with oncology and radiation oncology and surgery at multiple different institutions.
Great.
I'm sorry, that also, I apologize.
Go
That's the UC Davis Cancer Network, just where those multidisciplinary conferences occur.
Wonderful. I'm going to give it just another, I'm going to start to wrap it up, but if you have questions, I am keeping an eye on the Q&A box. I just really appreciate the time tonight. This webinar, again, has been recorded. So if you want to watch a recording, you can go to our YouTube channel to review it there. And also we ask a post-webinar survey. We love your feedback, how we did tonight, and what future topics you'd like to hear from on us. I think that is it. I don't see any other questions. So really appreciate your time tonight for both of you. Thank you so much. And I hope everyone has a good rest of your evening.
Great, thank you.